Good morning, everyone. Welcome to the April edition of Treat Live. Little off schedule this time, just due to SIR and everything. So I think we have a very interesting case today, highlighting some new technologies and some new data that just came out at SIR as well. I'm going to throw it over to, joining us today is our esteemed colleague Parag Patel from Medical College of Wisconsin, who'll be joining us to help us discuss this case and hopefully get an excellent result. I'm going to throw it over to Dr. Lookstein, who's in the lab today.
Thanks, Rahul. Thanks, Parag, as always. Love the group effort on these challenging cases. As Rahul said, I'm Rob Lookstein. We're broadcasting from Room 1 at Mount Sinai Hospital on the Upper East Side. To my right is my dear partner, Karema Garcia-Reyes, who's helping out here and helped us get this case set up. To Karema's right is our superstar IRDR resident, Chloe Cross. Chloe Cross has prepared a PowerPoint presentation, which she'll share with you in just a minute. Before we get started, I just want to take a moment to thank everybody who helps us get these cases set up. We're helped here in the room by our incredible tech, Debbie, wonderful nurse, Maya, amazing anesthesia team, my friend Barry, who's all come together to make sure that we can, do these cases safely with, the highest quality. And lastly, I say this every time, but I just want to give a personal shout out to our AV partners, BroadMed AV. They really take us to the next level, and their support every month is really unparalleled. So without any further interruption, I'm going to ask Chloe to put together put together the sort of history on this case, so that we can all start talking about how to manage these situations. Chloe, go ahead.
Hi, everybody. So today we'll be presenting a occluded venous stent case. She's a 57-year-old female. She has recurrent DVTs due to iliac vein compression. She had bilateral iliac vein stenting in 2020. She had a venoplasty done in 2025 of last year. Also of note, she had a PE in 2024 for which she had a thrombectomy. She also has chronic non-healing lower extremity wounds. She presented to us with worsening bilateral lower extremity pain, and she was started on Lovenox and Plavix. She was previously on DAPT, and our CT demonstrates bilateral iliac vein stent occlusion, which you'll see in a second. For physical exam, nothing too remarkable, except she has significant bilateral lower extremity peripheral edema. She has swelling and erythema. Our vitals were all within normal limits, and labs were also unremarkable. Next slide. So this is our CT venogram. As you can see, there's occlusion of both the bilateral iliac vein stents extending all the way down, and there's peripheral reconstitution. Next slide. So our assessment, it's a 57-year-old female. She had bilateral iliac stents placed 6 years ago. She's now has occlusion and edema with worsening lower extremity pain. And our treatment plan is a venogram, occluded venous stent recanalization, and stent replacement.
Thanks, Chloe. So just a couple of slight personalization. This patient was referred to me in the office, and as like many people who know my practice, a lot of people seek me out as a second or third opinion after being seen by other providers in the greater New York metropolitan area. She got very, very frustrated with the non-healing ulcers. She would be classified when I first saw her as a CEEP5 for sure. She's probably a little bit closer to a CEEP4 right now, but very symptomatic, a lot of inflammation, a lot of induration of both of her lower extremities, a lot of edema, and she definitely has venous claudication. Obviously she has, sort of crossing common iliac vein stents going into the IVC. If we could go into the first image that we had before this. Yeah, so this is interesting, and Rahul Parag, this is right when we were getting access, And you can see here that the stents, crisscross or, bang into each other at the iliac vein confluence. I don't want to, be really critical of this, but I have found that this technique for iliac vein reconstruction usually leads to clinical failures. And it also, as you can see here, there's a entire litany of almost every FDA-approved stent on the market. I see, several of the what we're calling second generation dedicated venous stents here. And hopefully we're going to offer this patient something novel, which was recently FDA approved. But, Rahul Parag, maybe you could comment on how you like to manage the iliac vein confluence.
I'll let Parag go first. Yeah, go ahead.
Thanks, Rahul. And thanks for inviting me. It's great to see good friends and talk about these kind of tough cases. The initial question sounds like, how do you manage iliac vein confluence lesions de novo? I think is what you're getting at, because typically we're doing unilateral reconstruction. If we're doing an iliocable reconstruction or involving both iliacs, it's often extending somewhere into the cava. But if we're going to do both iliacs, even if the cava isn't significantly involved, we tend to do more of a double barrel, where we extend that iliac stent up into the cava so they're more parallel in configuration, and then crossing like this. Alternatively, if it's truly an iliocable reconstruction, we'll put a large caval stent in and then try to land the two iliacs into there. But this type of configuration, to me, is the least favorable for long-term patency, because you're going to have overriding stents and or competing stents at an area where they can least afford it, and a little mural thrombus formation will start to create outflow obstruction for the other, and vice versa, and you get this situation that looks like you're in now.
Yeah, totally agree with you. Rahul, anything you want to add?
No, I agree. I think if there's any concern, if we're going to put kissing stents, we end up raising the bifurcation, even if it's a centimeter or two, just to get them in parallel, not this sort of T or overlapping configuration, because it doesn't work.
So I'm going to take you through the sequence of what we've been doing so far to set up this case. And there's a lot of interesting, I think, teaching points that I think Karem and I will share with you. But I think you see on this image, we were able to get a diagnostic catheter through with pretty extensive amount of work on the left side. And if we could go to the next run, once we got through here, you can see that the common femoral veins open. There's robust collaterals, reconstituting the left internal iliac vein, and then cross collateral filling up to the right internal iliac vein, and then very, very slowly this gets up to the IVC. My access was probably at the common femoral vein, femoral vein confluence, and then Karema, can you talk through how hard it was to get up on the patient's right side and some of the technical issues that we face getting up?
Sure. So the first thing is where to access, right? We want it to be below the stent, make sure we can cross. So big patient, so we were able to get small wire in, and then eventually upsized our sheath. I think the left side was a little bit more challenging, but we were able, with using a glide wire on the right side, we were able to kind of get up and then eventually upsize our sheath. So definitely, obviously, chronic change. There was a lot of collaterals on both sides. So and thinking, if you look at my side, we really accessed so we would have good running room to be able to have good pushability, and I think that was also key and why it was a little bit easier to get up there.
Absolutely. And so this was the venogram from the left side. Maybe we'll show the venogram from the right side now. And again, very, very similar. You see the common femoral vein offloading into the internal iliac vein. And then obviously you can see that the IVC's there. But of note, and this is a great picture, I believe, and I'm curious what both of you think, there's a little bit of inflammation and scar tissue at the iliac vein confluence, likely from chronic irritation from the stents. And if I had to guess, that's the mechanism of failure here for this patient. So it really reinforces not only from the venogram, but also just from our own past experiences that, this configuration where they're sort of crossing each other like an X or sort of driving themselves into the wall might not be the best technical setup to be able to ensure that there's long-term clinical benefit. And then we did, as we always do here, we did intravascular ultrasound to not, for a number of reasons. One is that we wanted to measure the inferior vena cava, the iliac veins, but probably most importantly, as I think we've all experienced, is that sometimes when you are crossing these chronically occluded stents, and she's been down for, based on her history, somewhere between 2 to 3 months, is you want to make sure that you're not passing in and out of the stent, because that can really make it very, very challenging for you to, either deliver anything, pre-dilate it, and prep it. So here you can see that this is on the left side. We're true lumen the entire way down.
Can we focus on the
into the
IVUS,
sheath.
please?
Are you all able to see the IVUS images? Oh, perfect. All right.
Yep.
So this is the IVUS on the left side. And there's the other wire, obviously. There's the stent. And you can see this is, very, very dense material inside the stent, and then going down. So there was no, extraluminal passage. And then I think the next run on the IVUS is the right side.
Oops, play. There we go.
And again, same thing. You can see the echogenic wire in the IVC. And then coming down, again, you see that crossing stent that almost obliterates the outflow of this stent. And then again, I'm very confident that we're true lumen all the way down. So there's a couple of issues here, and it's worthwhile talking about out loud, and I value everybody's opinion. We measured the diameter of the IVC where we thought that we wanted to land. I don't know if we can share that image with you, but we're getting 25 and 19 here, and that's a fairly representative image. And just as an example, I think we would all agree that a 20 millimeter implant is much too small to be able to confidently make sure it's going to adhere to the caval wall. We have a 24 millimeter implant, and then lastly we have a 28 millimeter implant. And I think it's worth talking about, how you've set up these cases. We are planning on using the recently FDA-approved Gore Fortegra system, and the configuration that was recommended in the trial was a iliac vein confluence or upside down Y configuration. So we're planning on implanting a minimum of 3 devices, a tube device in the infrarenal IVC, and then 2 iliac vein limbs that would sort of almost match a kissing stent configuration leading into the stem. So again, I'm open for conversation. I've been thinking about this, but I think the questions are: do we put in a 24 or a 28? And I'm curious what both of you think.
Where is this measurement, Rob? At what point in the is it right at the renal?
It is.
Below
It is about 3 centimeters below the renal veins.
Okay.
Yeah, and I guess the question is, does it dilate up further when you go up higher, or is it, because obviously what you're concerned about more so is
it stays very similar. It's probably a slightly larger at the level of the renal veins. I think we've all seen that. But this is where we're sort of at that pivot point of, do we Do we be, extra cautious and put in a slightly larger implant, or do we, sort of try and thread this needle and put in something a little bit smaller?
Yeah, my concern with the 24, which I think is sort of where you're heading, is that it's actually not really rated for a 24 millimeter vessel, right? It's really rated for like a 21 or 22 is sort of the sizing recommendation. So
yeah, right.
I'm not sure it's gonna fly, but I can't guarantee that it won't, So
I agree with you. So I think you and I are like-minded, and in full transparency, Rahul and I and Karema implanted several devices as part of the trial. We were one of the leading U.S. sites, so we have a lot of experience with this system here. It's a great system, and obviously we're very, very happy that it got FDA approval. We were also thinking of a 28 as well. So that's what we're planning on doing. In the meantime, and again, we can talk about a lot of different options and different configurations. I think we're going to start to pre-dilate on camera, and I think we're going to start with some 8 millimeter balloons. And I just want to make sure that they're going up seamlessly. So those are that's 1/8 on one side, and
so Rob,
a second 8.
Yeah, while you pre-dial,
yes, go ahead.
Parag a question. So, it's an interesting problem, right? So it's clearly not acute clot, right? It's a mix of some subacute and probably a lot of chronic clot versus fibrous material. You're going to balloon dilate. And I know what you're going to do, Rob, but like, what would you in this situation do, Parag? Would you try to remove or scrape some of the inside of this stent, try to suck, the acute stuff out if there is any?
Yeah. Yeah, so this is the bigger question for me isn't so much the cable size. I think the 28 is the right way to go, and that's less controversial to me. It's in this redo iliac system, what size stents are you going to get, and how big are you going to get open to provide inflow to that cable stent? The 28 is going to be fine. Typically for me, an iliac at this location is probably something like 14. 16 is pretty big, but that's just mine, typical, but I've done both, and I'll use IVUS to drive that. You have a challenge here because IVUS is showing you where you're at intraluminally, but you have residual thrombus that you're not going to be able to clear all of. And so I try to focus a lot on debulking as much as I can so I can get a better luminal expansion. So I start with balloon inflation. If it was truly acute, your wire flew, then it's a thrombectomy case all day.
Yeah.
But if it's like this, I would balloon dilate like you're doing. What I often find is that some acute portion, because there's probably some mixed age stuff in here, a lot of fibrous stuff, but also some subacute perhaps. And you start to loosen it up a little bit. And I've actually gone to doing some thrombectomy in these cases still to try to remove debris. Because if you just squeeze it, up against the wall and create a sandwich, you don't get as optimal a gain. And after the fact, more ballooning will not help you in that endeavor. So that's been my experience, and that's where I've trended to. So I like what you're doing. It kind of tends to break up stuff. You might get fronds of tissue that's a little more amenable to aspiration or thrombectomy, whatever system you're using, and then try to debulk from there to get a better luminal gain with the new stents, relining it.
Yeah.
Can we have the 12 millimeter balloons, please? Sorry, you guys keep going.
And so the other thing is, they Rob and Karema were able to cross with just a wire and a catheter, but in these occluded stents, these second generation stents are a little easier, but we still see some old school wall stents come back, and those ones are notoriously difficult to cross true lumen. Do you have any other tricks that you use to cross these?
Yeah. So when I was looking carefully at the CT scan that showed at the case presentation, I was happy to see, and I hadn't seen the wire passage at that point, but I was happy to see that the bottom end of the stents had some flow into them.
Yeah.
I often find those stents when they're occluded, as you mentioned, the earlier generations, or they're fully occluded from the top to the bottom. The hardest part is just trying to enter into that stent lumen. You can get around the stent. I've been around the stent, almost like a subintimal passage, not really through there, and the hardest part is breaking through. So I've actually had to go to needle reentry systems to try to pierce through that cap and confirm. And once you're in that lumen, then you can work your way through pretty good. But that's the hardest thing oftentimes, is to triangulate and get back into there. And wire catheter in that situation becomes a much more challenging process. And I've had to use I've gone re-entry devices. I've used sharp needle recanalization, different techniques to pierce through that and then work my way through the stent.
Yeah, that's good. I think for a long time, we use the needle, either the back end of a glide wire just to start that cap. What invariably I find is that you find a cap, it's sort of easy to cross, then another cap, then you have to kind of do this sort of work your way up. And so, either a glide wire, I've even gone to like a tips needle, a colapinto needle, something really robust, something I can angle in, and that can be really tricky.
This is interesting. Just to step in, you see that massive waste we saw at the iliac vein confluence. And again, it just goes to this theme that we're expressing here, which is that when you have crossing stents here at the confluence, it's likely going to induce more of an inflammatory response than you'd really like. And I think that's one of the well-recognized failure mechanisms, is that this configuration really leads to an outflow problem of the iliac veins.
What size balloons are those, Rob? You have in
right now? It's 12s. So we did 8s, and now we're going straight to 12, and we're getting a lot of waste here, a lot of resistance. This is very organized stuff for sure. I think you'll see when the balloons go up, it's just all scar tissue here.
Yeah, so the other way we've crossed to is we've moved a little bit towards the RF wire. They have a new system from Venous, right? That has it basically doesn't turn on when you get to the edge of the stent when it hits metal. So you can't really you can, but it's a lot harder to burn through the struts of the stent, and that seems to have helped, because sometimes the needle, you just can't get the needle to engage. And these can be really hard. Or also the other thing is just kind of come from above and below and try to meet somewhere in the middle.
Yeah, absolutely. I like the RF wire a lot in this application. Some chronic total occlusion. Certainly, we've used it a lot more upper extremity, central venous, but this is a great application.
So you guys are going through the whole deep venous toolkit, so to speak, but I think it's a really important message that people that want to do this kind of work, that they have a depth of equipment. Just as one example, we're using what I'll call high pressure balloons. The balloons that we've been using right now are of the Athletis variety from Boston, which are very, very nice balloons. They track very nicely. They're very high pressure balloons, and they're really, really great for these kinds of applications. I think if you don't have high pressure, certainly 035 balloons, you're probably not going to get the kind of, again, luminal gain that you would normally hope for, and that can lead to some technical issues also. You spoke about RF wires and crossing systems. Parag, how do you escalate if you're stuck? I think you alluded to this a minute ago, but if the wire sort of in the center of the stent's not going, how do you typically escalate? And what's your thought process?
Right. So, I mentioned, and we've mentioned a few different ways to break through that initial cap. And then I'll de-escalate to try and see if I can just get the wire to pass through. And I think as Rahul nicely described, you'll get a little ways through, and then you'll hit another roadblock. So then you have to escalate again. And so for me, the beauty of these cases is once you're through the cap, you have the stent outlining where your muscle.
Yeah, right here. Let's go right here.
You can triangulate and use obliquities to make sure you're not exiting. Secondly, it's a low pressure system, so if you do happen to make that mistake, you can redirect, pull back, and you're not really losing. But that's rarely the case. I think as long as you're kind of using obliquities to work your way through and make sure you're within that stent. So then I'll take I usually will go coaxial or triaxial and try to cross through this to give myself a little bit more leverage to push through if I'm using a wire catheter system, and then escalate up with either the RF wire, which was mentioned, or a long needle. The tips needles, the skinny needles, whether you use a colapinto or a rush needle, we have long sheaths that can then track to where you're at and continue to pierce your way through. But then de-escalating once you get past that hard point, so that you can, kind of use a wire for me to get through the rest of this. The critical piece is at the top, and at the bottom is typically where the concern for going through stent struts are. And so I'm more careful there and use exactly what you did, which is IVUS. And typically the catheter is not going to track over the wire if you go through the stent interstices, but IVUS it really tells the truth.
You were talking about, maybe, it's a low pressure system. You don't have to worry about bleeding and stuff like that. What do you do for your anticoagulation stuff during the intraprocedurally? Do you hold it? Do you just keep it going? Yeah.
No, so I'm generally fully anticoagulated in the procedure. So I mean that technically could raise a point, but again, it's a needle puncture hole or a wire hole. I'm not escalating
one at a
balloon
time.
dilation. I'm very careful about making sure the wire path is where I want it to be intraluminally. Then I can go, as you've done, really high pressure balloon inflation and really being aggressive about that is very much how I handle that. So I have no problem with that, but I like these to be anticoagulated. I think you will find yourself fighting thrombus in the case if you don't, and I worry about that. And then also in these cases, it's in a very aggressive post-procedural anticoagulation, and in our patients, I follow them aggressively with at least initial trial of a dual antiplatelet. It's a pretty aggressive regimen. I'm Lovenox, aspirin Plavix for the first month.
Oh, wow.
For many of these patients.
That is aggressive. Yeah, we definitely do, at least my practice, we definitely do Lovenox for 2 to 3 weeks until their first follow-up. And then once that shows everything's open, we'll switch them to a DOAC. I haven't done dual. I've put patients on aspirin on top of Lovenox, but I haven't necessarily done the aspirin and Plavix. But maybe for these dense ISRs, might be worthwhile to try it.
Yeah, I follow them aggressively 1, 3, 6, and 12 months. And at that first month, sometimes it's at 3 weeks, everything's looking open. I'll switch them from the Lovenox to DOAC. And then at the 3-month, they're absolutely no longer on DAPT, but just DOAC and aspirin. And at 6 months, it's really going to be dependent on their hypercoagulable workup, but they may continue on a DOAC for life, or they'll continue that and no longer than 1 year, just depending on the stent configuration and how concerned I am about the patency. This is the trouble we have, is these stents that go down, generally the patency, it's very hard to manage if you as opposed to doing it well the first time. And this isn't this is more of a lesson. I don't know who the operator was here, and I know they intended well, but it's just harder to get that same long-term patency when you have to do these reinterventions. So, but I think finding the problem, as you did here with the confluence and the crossing stents and getting a better stent configuration with good follow-up, which I know you guys do in your practice, he's going to have a better chance to stay open with maybe reinterventions that are scheduled as opposed to due to an occlusion.
Yeah, exactly. Yeah, these are definitely easier to manage when you just see like a little stenosis or something in there, as opposed to they're completely down. All right, so
okay. So we just upsized while you guys were chatting to dry seals, which is recommended to place the Fortegra system. We're all set here. I'm just going to do a venogram just to show that there's no, major issues, obviously. And I don't usually do this. I just trying to reinforce the idea of always be thoughtful and make sure that everything, looks satisfactory. All right, and so that's our mark for the renal veins, obviously. Now, what we're going to do is we're going to take a 28 by 75 device, which, do I have that on the table? Yep, thank you. And we're going to try and land it exactly at the renal veins, maybe even crossing the renal veins slightly. The one thing that I will say, and this was borne out in not only in our cases that we participated in, but also in the trial data, which was really excellent, and it was presented not only at Viva last fall, but just last week at the SIR annual meeting in Toronto, Canada, was that the patency was really best in class, and the lesions that were treated included 40 centimeters of length. And so the most common configuration was a very long treatment zone in the inferior vena cava, as well as both iliac veins, and I alluded to that before. And so the fact that we're seeing really unprecedented patency for such long stented lesions, I think, goes to the durability of this novel design for this implant. So I'm going to introduce this. want to make sure that we're going in without any resistance at all. There we go. Okay. There's the device. And I think this is going to fit perfectly. This is a really good length. So just to repeat, this is a 2875. We're really right at the renal veins. And then obviously what we're going to have to do is we're going to have to retract the other wire, which I think I'm going to do now to make sure that we don't jail it. Not that I'm really worried about jailing it, but I'm hopeful that we can configure this and just be able to get the second wire to go up seamlessly inside it. Okay.
So, Rob, when you're really easy prep, it's just to flush. And then when you're deploying this, usually you're targeting a centimeter or two above where you want
I usually want it, you know, we on the last venogram, we saw that it was, the renal vein was about at the superior end plane of L2. So you can see, I'm just going to zoom up very briefly here. The radiopaque markers, obviously, on each side of the stent. Okay, and so we're a little bit above the renal veins, and we're going to just center it so that we're back exactly where we want to be here. And I'll tell you, I really like this location for this. Rahul, any comments before we let this go?
No, I think it's good. I think you're going to be just encroaching on the bottom of the renal veins. You know,
that's
I think
correct. That's the plan here.
Yeah, people always raise this concern about covering the renal veins or covering the hepatic veins when doing these. Obviously, here it's not really an issue because I think we have enough running room to land it. But
correct.
You know, what's been your experience, Parag, in terms of, you know, how do you manage the renal veins? Do you worry about them?
That it's going to come back a centimeter.
No, I mean, so I like the landing here, by the way, and I don't mind encroaching on the renal vein confluence. It's not a small, you know, confluence. Typically, the renal veins has a fairly large and angulated upwards type of configuration. You're going to be just fine. I think you worry about not covering enough of the involved cava. And here you need the running room to get those parallel configuration of your iliac stents.
Absolutely.
And if you run this too short, you end up putting those stents almost parallel to the top of this, and then you've defeated the purpose, I think, of why you did this. So I actually like this position a lot.
100%. I think we're going to go, if everybody's in agreement. Karema is going to deploy it. This is a pull string configuration, typical to the other Gore products. And again, I think we landed that perfectly. Again, we were thinking that the top superior end plane of L2 was going to be where the renal veins were going to come in, and I think we're, again, within 2 or 3 millimeters of that. So the accuracy is really stellar. Now, this is a very important point, and I'm going to just highlight this, is that the nose cone right now is at the top of the screen. And what I'm going to do is, as Karema pins down the wire, I'm going to push up the device, release any tension in the system, and just rotate it gently as we're coming back. Karema is going to start to pull it back. And we're going to just make sure very slowly that we don't capture the device. And that looks really smooth. And that's a really important technical point here. And I think that as we get, you know, more comfortable and we're doing a lot more clinical cases, that we're going to start to see people learning all these great technical tips for this device. So this worked out beautifully. We're almost out on this side.
Can you open it a little bit, Rob?
Yep. Give me 1 second. And I think you can come out now. There you go. And we're locked on this side. So now I'm going to take a diagnostic catheter up this side.
It's like an EVAR cannulating your contralateral gate, you know?
Exactly. Which is one of the benefits of having these long sheets here. It really is like an EVAR case almost.
Already up there.
I just want to make sure that we look good.
Yeah, it looks like it's in the middle, right?
I want to be OCD about this.
Yeah.
Can I have a pigtail catheter? Since we're talking so much about yeah, we're talking so much about EVAR, I would hate to skip a step and look like a fool. So it's, you know, we have everything under full control. It's really good to be a little OCD about this. So I just want to convince everybody who's watching this for educational purposes that if you really want to be 100% sure that you're not behind the stent, the best plan is to introduce a pigtail into the center lumen of the tube and spin it, which obviously if you are behind the device, you would not be able to do that. So we're going to go through this exercise. It might be overkill, but we're really talking about safety and we're talking about providing really high quality work for the patient here. Patient, you know, came to get really excellent care, and we want to make sure we don't skip any steps to make sure that she has a very, very durable result. So here's the wires coming back. And again, I'm just, looks perfect, right? Everyone agrees there's no way I could be doing this if I was behind. Okay, excellent. All right. Okay, so now we're going to take the 16 by 150s. And you know, when you're putting in a 28 millimeter caval implant, the recommended configuration, even though it might be intuitive to say, well, if I put two 14s into a 28, it should be fine. There have been countless bench models that show that you really want a little bit of oversizing right where the limbs meet at the confluence, and that creates less turbulence actually. And that's what we're going for here is the most durable result. So we're going to put two 16s and we're going to overlap it with the tube there by about 3 centimeters. We're almost going to go halfway up. And then we're going to go down as long as we can. We might end up with, you know, 5 implants, but we'll see how these 150s look once they go inside.
Cross-face wire. There you go. I got wire.
And then obviously once they go in and we agree on the alignment here, Chloe and Karem are going to help me deploy them. So that's one. And I like that amount of overlap for this. We're probably going to need 5 pieces if I had to guess.
A wire?
Mm-hmm.
You deploy these. It's just like a Viator. So you just
yeah.
Okay. So again, here's the configuration. What do you think, Rahul Parag? You think I should go up with these limbs? I don't need this much overlap. What do you think?
I think it looks good. I want them to be parallel, and that's what you're seeing occurring here. I don't think you need to go higher. I don't think.
Okay.
But,
so most importantly, obviously, I'm going to retract the dry seals down.
Right.
So that we don't deploy the devices inside the dry seals. That's a pretty important technical note. Okay, so now you can see they're in the external iliac veins. Go ahead, Rahul.
Yeah, so one thing I do like about deploying these in parallels, you can do it as a one-man operation, right? You can take one hand, grab both of the handles, and then pull, you know, with one hand both strings. Although it is a very long string because it's double the length of the stent, so it ends up being, you know, a lot of length to pull. But you can do it as a one-man operation.
Okay,
as opposed to the wheels or.
We like this right now.
So unscrew.
Speak now or forever hold your peace. Okay, we're going.
Okay, so unscrew. It's going to be a really long. You're just going to keep pulling. So start pulling and then look at the screen. Start pulling. We're trying to go at the same time.
Yeah, I'm pulling.
You can see. I'm stopping for a second to get more. You see mine
really long.
pulling. So, so I'm going to wait till you. Keep watch going. The screen. Yep, perfect. And now we're going to go together.
Yep.
Stop. And then now we're each on our own side, so it's okay. Perfect. Great.
Excellent.
Really
okay, same principles. Same principles of the nose cone. So we're going to start here on the right side, bring it up. And again, just very gently, I'm rotating it as it's coming back to make sure we don't catch the iliac limb. All right, and this looks really good. I'm not getting any resistance whatsoever. Okay, and we're going to come out in a second. Okay.
You got wire?
Yeah, no, not yet.
Pin pull.
Got it. Okay, excellent. And now the other side. Same principles, pushing up, reducing the tension in the systems, and then just spinning it gently as you're coming down to make sure you're not catching the ledge on the top cap of the stent. And we're well within the central lumen, and we look good. Okay, excellent. All right, we're going to need extensions. So I'm going to say, can we have, do we have 16 by 100s? Yep, I'll take those.
So how low are you planning on stenting, I guess? Just covering
I think I'm going to go into the middle of the femoral heads on both sides.
Okay.
Say that again?
Yeah, 200s.
We mean 2 100s. Yep. So Rob, can I go back to, when you saw this patient in office hours, you changed her anticoagulation. Can you talk a little bit about that?
Yeah, sure. So that's a great question. So it's very important for me, and we haven't spoken about this yet, in at least extensive detail. Parag said he puts everybody on triple therapy. I think it's really important in the post-procedural period to have people on low molecular weight heparin, and it's much more important for that in terms of subacute technical success. That's really critical. And so I always will get a patient on low molecular weight heparin in my office hours leading up to what has increasingly become a outpatient procedure. And so this patient was transitioned from a DOAC, actually, without any antiplatelet agent, to low molecular weight heparin. And I like this length. This is really good length here. This is perfect right here. And to low molecular weight heparin and an antiplatelet agent. And so this is our routine protocol that we engage with patients on pre-procedure anticoagulation way ahead of time, and we manage it expectantly from there. So I'm going to cheat a little bit here. Okay. These don't obviously need to be done simultaneously, so we're going to do the right one first.
Okay,
go ahead. Excellent. Okay, and let's do the. I'm going to give another. Another millimeter. Go ahead.
So it takes a little bit till you see it. Yeah, there you go.
Excellent.
Great.
Perfect. Okay. So those were clearly the right lengths. And again, this goes into what we saw in the trial, about 40 centimeters of coverage. So same principles. I'm going to push up the right side, just spin it a little bit as it's coming down. Make sure that there's no resistance. And if you guys want to walk it out.
Walking it out. Make sure it's coming.
Oh, hold on.
Yep.
Saw the resistance there. All right. So it's same thing. Push it up. Very important. I hope everyone saw that fluoroscopically. Karama, you can rotate it as it's coming out. I'm just going to stabilize the sheath here. No, we're still catching it. All right. So I'm going to take this all, pin down the wire.
I'm pinning.
Bring it all the way up. Okay.
Can you just ride?
And then again, we're just rotating it. Rahul, you were saying?
Yeah, and you could also just ride the sheath up
back.
over the stent apparatus to capture the nose cone too, right?
Yeah, I just want to see if we can resolve that. That's a great idea. Thank you.
Coming. That's better.
Or you can do that.
Yeah, there you go. Great. Perfect. So that was really key to be watching that coming out under fluoroscopy and make sure we don't, lead to an issue that we weren't anticipating. I have the wire. It's great. Okay. And then the same thing on this side. Can we open up the 14 millimeter balloons, please? So again, I'm going to push this up. Make sure we've, again, reduced any traction, any resistance in the system. And we're coming down under fluoro. Really important teaching point here to watch it coming down under fluoro, making sure you're not creating any kind of tension in the system. That went much more smoothly. And then we're out. Excellent.
Hey.
Okay. So I think we're going to post-dilate this whole thing to 14. We'll try and do a venogram. I think the most important area you already can see here is the confluence, where there seems to just be a lot of extrinsic force there, which really goes into this idea of, how aggressively can you dilate it, and can you open it up? I think this is going to be, critical to ensure that this patient has long-term success. So I think we're going to post-dilate these limbs to 14. I think we're going to probably do a venogram, and then we'll get your all feedback. And then I think we can probably call it for the day, and then we can just touch up everything else off camera. I want to be sensitive to everybody's time who's helping us here, obviously. There we go. So that is, I think the balloons are well matched. Yeah, let's do this. All right. So these balloons are Atlas balloons.
Okay, ready?
And again, these are, for lack of a better term, kissing 14s.
First.
Great. And we're just going to sequentially go down. I've got the sheaths. Nice and slow, guys. Stop there.
Yeah, you see my button.
So hold on. I'm not. I just want to make sure I see where the balloons are.
Show me the mag one.
So this balloon is right there at the confluence. This balloon is also right there at the confluence. No, I see. Okay, now, all right.
Yeah.
That's why it's always good to have great partners. So again, coming down a little bit. Excellent. Thank you.
Okay, ready? Okay.
Excellent.
Okay. Down.
And again, I think the next inflation is really going to be the critical area where we get this outflow established.
Yeah.
So there we go. We're right across, and same on this side. We are right across. This is going to be critical.
Okay, ready?
All right.
Waiting for you.
We should go right up to burst, because if we can't get this to open, I'm worried she's going to have problems again.
I'm rated.
I am there too.
That looks great.
Yeah.
Absolutely stellar.
Okay,
Great.
Opened up nice. Nice.
Yeah.
Yep. You saw the sort of outer wall expand, and I think we probably got at least 4 or 5 millimeters of luminal gain right at the confluence from that inflation. So that was really good. Excellent.
Do you want the map?
And here, and here. Go ahead. And down, and down. So before she came in this morning, she was on full dose therapeutic Lovenox, and we've given her supplemental and fractionated heparin in the room. And as I think I said, she was on single antiplatelet therapy before she came in. So we're really trying to make sure that the patients are fully therapeutic before they come in.
She's okay, right?
Yep.
There you go.
Go ahead. Okay, so I want to bring the left side down and go right here. Let's do this.
Okay.
On the left side. Yeah. Excellent. Okay, now what I'd like to do is I'd like to put the dilators into the sheaths again and get the sheaths re-engaged. Because we retracted the sheaths so much, I'm concerned about causing damage to the stent column by reintroducing the sheath, especially if there's not a dilator inside it. So we're going to do that now. I have the wire on the right side.
Dilators.
And Rob, what wires are you doing? These are I know which wires, but
these are Amplats. These are Amplats wires. I personally think it's much safer to do these complex venous reconstructions over Amplats. I don't like doing them over less supportive wires, and so that's my preference. Again, I'm watching the right side very carefully under fluoro to make sure that the sheath is in a safe place. Okay, and again, we're going to walk out this dilator here. And then we're going to do the same thing on the left side.
You got sheath, I'm pulling balloon.
Excellent. And then again, I think we're going to try and give you a money shot and then see where we are. And we'll obviously probably have to do a little bit of touch-up work offline, but we're probably at the hour. And so I just wanted to, we've been working, as you can tell, feverishly hard. I think we got a lot done, a lot of really good teaching points about how to use this new technology. And we're going to share with you what the acute results are in just a second. Again, the sheath went very smoothly, so I'm glad we put back in the dilators. Very important technical point again when you're doing complex cable work. Okay.
Contrast.
Right. Yep, 20 cc's, 50-50.
What are you looking for, Rob, on this completion? Are you doing simultaneous injections through both sheaths?
Yes, absolutely. As I like to say, brilliant minds think alike. Okay, so let's get a slightly better view here. Okay.
That looks really good.
Nice.
Really good, right?
Yeah.
So obviously we're gonna do IVUS, and there's a lot of other things that we want to just make sure that we're touching upon. But it looks like there's good inflow. I want to optimize that. That's probably going to take us a little bit amount of time. But I really appreciate all the counsel on this case. Of note, which I really like, is how the confluence is basically reconstructed now. It looks much better than it did before. And then again, just from my experience, I really think that was the failure mechanism for this patient all along. So I think using a dedicated device for the iliac vein confluence bridging into the IVC was the correct strategy here. Rahul, Parag, any closing comments before we let you guys go out?
From my standpoint, it looks great.
Yeah. Great job, great team. You're lucky to have Prema help you out there, and I think you have a lot of experience. It shows that confluence looks so much better, and that's exactly why these need to be done this way at the de novo reconstruction. So good job saving this.
Absolutely. Parag, as always, thank you so much for joining us this morning. You know, really, really great wisdom from a very, very close colleague and friend at MCW and a past SIR president. So Parag, sincerely from everybody at Mount Sinai, thank you so much.
Thanks, Parag.
Have a great weekend, everyone. Bye.
Thank you.